All right, so now we're going to start talking about HIV. And do not make this crazy. When it comes to HIV, this is not a big deal anymore. People are living with HIV and AIDS. If they're taking their medications, they're actually pretty okay. We have perfect examples in the media, people like Magic Johnson, people are living with it. So it's no longer like COVID, right? I mean, once upon a time was a big deal. It really isn't. So all we care about now with HIV and AIDS is just about prevention, how not to get it, and how not to spread it to other people, right? And just really it's all about teaching and making sure that if somebody does have HIV, that we actually can make them take their medications properly so that their viral load is basically decreased. That's it. Those are the main points when it comes to HIV. This is a chronic condition at this point, and people are living with it longer and longer. All right. So biggest thing with HIV infection is that it causes immunosuppression. So that's the other word, immunosuppression. A lot of people that end up dying from AIDS, it's because of the immune system is suppressed, so they actually end up getting opportunistic infections. So normal things, regular things that normally a regular patient wouldn't get sick from or even die from, patients that have AIDS end up dying from that because their immune system is just shot. All right, so at least 1 million people currently in the US are living with HIV. There's about 36,500 new infections occurring in the United States each year, and literally the treatment has been phenomenal. So that's why people are actually living longer. If you were to guess, which group of people do you think are getting infected more and more? So there's a hint. It's like near the end of the slides, but hopefully you guys guessed it. All right, so it's all about contact with certain body fluids. So in particular, we're looking at things like blood, semen, vaginal secretions, and breast milk. All right. So right off the bat, that's pretty much everybody, right? So male, females, babies, right? Pregnant women, there is a risk there when they're giving birth that they can actually give birth to a baby that has HIV. But if they're getting their medications, right, because you can't stop somebody from having a baby. So just because they're HIV positive, you can't say, hey, you can have a baby. If they want to have children, that's their right. As long as they're taking all their meds, the risk is actually pretty low now because with all the different advances in medications. So you know that HIV is not spread through casual contact. So hugging, dry kissing, shaking hands, sharing eating utensils, using toilet seats, none of those are the ways that you're going to be getting HIV. Once upon a time, everybody was freaking out because they thought that you could get HIV basically from this way. Under sexual transmission, this tends to be the most common mode of transmission. So it's the greatest risk is for the partner who receives the semen. So whether it's a male or if it's a woman, whoever is getting the semen is usually the one that's most at risk. The other factors have to do with prolonged contact with infected fluids. Women are at higher risks just because of our anatomy, and we're basically like a reservoir. And if you're involved in any type of sexual behaviors that cause trauma, like shearing and tearing, then there's a higher likelihood of transmission from that as well. In terms of getting it via blood, so if you're using things like drug paraphernalia, right, that actually is very risky behavior, right? So some of the other issues with people that are using drugs is that they're high, so they have no idea what's happening. So for all they know, they're using needles, that are covered with blood, or maybe somebody has a cut, and they don't know what they're doing. So even things like if you're drinking, all of those types of weird behaviors that kind of alter your mental status where you're not really clear, those types of things basically put you at risk. All right. So with the blood stuff now, we've been doing a lot of preventative type of strategies to make sure that people are not getting infected. So even with people that are using drugs, there's a whole bunch of different programs where they can get clean needles, right? I know that in Canada specifically, they have centers where people can go and actually do drugs in like safe environments because they're monitoring them and they're watching them. I know that here we do have the needle exchange programs where people can show up and get the equipment that they need. I don't know if we have centers where we watch them specifically and they can get high there. I don't know if that's happening here yet. So blood risks are also decreased because the blood donors have been screened. In terms of the healthcare setting, it has to do with puncture wounds. That is the main way that people can end up getting the HIV infection. But even with a puncture wound, it has to be like a really big cut, or it has to be like a large bore needle. Those types of things are kind of the reasons why somebody may end up being infected, because they're still saying that the risk is pretty low, even in the healthcare setting. If your patient maybe has a really high viral load, let's say, and there's visible blood that exchanges when you get stuck, then that's probably why you might get infected. There are certain units that may put you more at risk, like if you're working on a psych unit where somebody maybe is a little bit crazy and maybe you're trying to draw their blood and then you drew their blood, but maybe they grab the needle from you and then they stick you with it or something weird like that, right? So there are some certain units that you may be more at risk as well. All right, so perinatal transmission is a real thing. It can happen, but like I said, it's really not that high. So if the patient is taking their medications, if the mother's taking medications, the rate of transmission is as low as 2%. All right. In terms of HIV itself, so it's a ribonucleic acid virus. Apparently, they replicate in a backward manner, going from RNA to DNA. And the main takeaway you need to remember is that they're targeting the CD4 T cell. And it's a type of lymphocyte that is incredibly important in terms of our immune system functioning and keeping us safe. That is the main takeaway from all of this. All right, so nice little picture here, basically showing you how HIV proteins bind to a cell. And then the whole thing goes through a process, and then you're ending up with things like cellular destruction. So the other important thing to remember is that we have a whole bunch of different medications, and different types of medications target the HIV process at different stages. So you may have medications that are specifically targeting transcription, right? Or you may get medications that are specifically targeting replication. So just know that the different medications we have, they target different processes from our cells basically being taken over by the virus. All right. Once the cells basically have been taken over, you get this viral DNA that makes a new HIV, right? And that becomes a problem. So the biggest issue, once again, is the fact that our CD4 T cell counts are attacked and they drop to less than 500. So severe problems, including AIDS diagnosis, happen when the CD4 count is less than 200. Our normal CD4 for a healthy immune system should be from 800 to 1200. So remember what I said, in HIV, what happens is once our CD4 is like less than 500, that puts the patient at risk for opportunistic diseases, and that is usually why the patient will die. Just a quick picture here showing the relationship to the number of CD4 cells over the spectrum of untreated HIV. So number of CD4 cells to viral load, and just showing how this progresses. So no need to memorize this either, but knowing that there's a particular phases. So in the acute phase, it may take a while, but your viral load will be high about 6 weeks or so, like between 4 and 6 weeks. It gets really high. So if you got infected somewhere over here and they were to do any testing, they may not even catch it at all, because it takes a minute for it to cook up in your body. All right. So this is, the patient actually is very, very infectious, pretty much at any point here, but especially here when the viral load is really, really elevated. All right, and then so now, like I mentioned, the disease is pretty much chronic at this point. People are living with it, and now you're just seeing how this affects your CD4 count. So the longer you have it, the number goes lower and lower. All right. You're looking at the viral load here. So the longer the patient has it, you're seeing that the viral load increases as well. If it's not being treated, that's the problem. Okay. No need to memorize this either. So different phases, once again, acute infection 1 to 3 weeks. They're able to get the test results better between 3 weeks to 3 months, right? Unfortunately, the patients can be asymptomatic within this phase as well. So once they've gotten sick, the weird thing is within the acute infection, within the 1 to 3 weeks, they have those flu-like symptoms that they get. And then it transitions. So if it's not being treated properly, then it's going to transition. Then they can get into this phase where they're asymptomatic. And then obviously the higher the viral load becomes, then they're going to start getting opportunistic infections, ending up with AIDS, and then it gets worse for them. Okay. So biggest issue is the fact that the acute infection sometimes is missed. So it looks like mononucleosis like symptoms, so fever, swollen lymph glands, those types of things. Sore throat, headache, malaise, nausea, muscle and joint pain, diarrhea, and or diffuse rash. So very vague manifestations. And so usually people are like just ignoring it, but this is when the patient is incredibly infectious. Okay. Then it progresses, obviously. In a lot of cases, they're saying that a diagnosis of AIDS is made about 10 years after initial HIV infection, and that is because people are asymptomatic and then people are not even going to get tested anymore. So within that time frame, people may still continue in the high-risk behaviors, not realizing that they've been infected. And maybe they thought they just had a flu, they ignored it. Maybe at the time they got it, their immune system was pretty strong, so it's kind of trying to fight it off a little bit, but then the HIV is still there. But then it progresses as the viral load increases and replication keeps going on. And the HIV virus is basically integrated and is taking over your whole DNA replication that's happening. Okay. So here, the symptomatic infections basically start when the CD4 T cells decline closer to 200 cells, and then now they're advancing basically to the more active phase. All right. So this is when you're going to see really bad symptoms happening in the patient. So persistent fever, frequent night sweats, chronic diarrhea, recurrent headaches, and things like severe fatigue. So all of these things you may be seeing in your patient. So we have a couple of pictures here of some of the things that will happen once the patient starts getting things like the opportunistic infections. So here's just a picture of the oral thrush. Basically that's in the hard and soft palate. So that's how that may look in your patient. So very distinctive features though. I mean, once upon a time you used to see patients like this all the time in the clinical setting. They used to waste away. They used to be really, really skinny. You really don't see patients like this anymore. And it was really horrible. Wasting away, diarrhea, nausea and vomiting, like really, really bad, right? But very, very distinct manifestations. All right, so some of the manifestations you're going to see in your patient. So once we're getting into the AIDS phase, our CD4 count is 200. And remember what we said our normal range should be. So at this point, our immune system is not, it can't do it. It cannot, protect the patient anymore. So little things that normally other people would not be getting sick from, these patients unfortunately are getting really, really sick from them. So shingles, female patients may be getting things like persistent vaginal candidal infections, oral genital herpes, bacterial infections. All of these things are happening. This one is very characteristic for AIDS as well. So here you're seeing Kaposi sarcoma lesions, very, very distinct. All right. So some of them are large, different colors, different skin surfaces, just all over the body. Okay. And then a picture of an oral hairy leukoplakia on the tongue. Okay. So there is diagnostic criteria that is basically established by the CDC. They have actually different phases of that as well. By the time they've determined that the patient has AIDS, once again, CD4 count is incredibly low and the immune system is severely compromised, right? So patients will be getting things like infections, malignancies. So think now, always think bad, right? Wasting syndrome, HIV-related cognitive changes. So they may get things like HIV encephalopathies, like really, really bizarre things that start happening in the body. All right. This is just a chest x-ray showing interstitial infiltrates as a result of pneumocystis jirovecii pneumonia takes over. So all of these other types of things happening. Okay. So all we want to do is find out what the viral load is, right? So we're looking for HIV-specific antibodies and or antigens. So remember what I said, in order to detect the antibodies, there's a window period, right? So we can either be using blood or saliva, basically just to find out whether or not the patient is positive. And now we have a lot of rapid tests that they do, right? So the testing has really advanced. Okay, so biggest thing is, in order for us to know whether or not treatment is effective, we are looking at the CD4 cell count as well as the viral load. Those are the two main things that we're looking at. The higher the viral load, the worse the disease is. The lower the viral load, the less active the disease is. Obviously, the higher your CD4 cell count is, then your immune system is functioning pretty well. Okay. Patients that have AIDS will have abnormal blood tests a lot because of the opportunistic diseases or complications of therapy. Some of the medications that the patient is on also really, really do a lot of damage to your immune system itself, but to the blood levels, hematologic system. So some things that you may see, like decreased WBC counts, low platelet counts, anemia directly related to the therapy, altered liver functioning. So this is actually one of the reasons why some of the patients actually didn't even like taking some of those medications, because the side effects from the medications were horrible. Okay. So what do you want to do? So like I said, this is not a big deal anymore. We're basically just giving medications. We're monitoring the patients. The biggest thing we want to do is to make sure that they're taking their meds and that they are following the therapy. They're not spreading it to anybody else. Okay? You have a patient, regardless of age, you pretty much treat every patient as though they were HIV positive, right? So remember your standard precautions, but you never make any assumptions. Kids are having sex much younger these days. Older people are having sex. So just because the grandmother shows up, she's 90, don't assume that they're not having sex, right? Everybody's having sex. You always assume that. Stop making me laugh. Your grandmother was having sex, babe. Oh my God. Anyway, your first patient visit, you're going to gather the baseline data. You're completing a history and physical examination, and you basically treat every patient as though, that they need the information is your main takeaway. Drug therapy, decrease the viral load, maintain and increase CD4 counts, prevent HIV-related symptoms and opportunistic diseases, and delay the disease progression and prevent HIV transmission. This is a fun lecture, babe. All right. So if a patient ends up with an opportunistic disease, that's what complicates the infection itself, right? That makes it harder. So if your patient ends up with things like Kaposi sarcoma, a wasting syndrome, those types of things, and obviously then the treatment is harder. So prevention is always key. Prevention is prevention, prevention. Onset can be delayed with adequate measures. Effective management has significantly increased the life expectancy. So you're going to keep hearing me saying that over and over again, that you need to just make sure that the patients are taking their medications once they've been infected. So they have this thing known as preventing transmission of HIV via PrEP. So this is pre-exposure prophylaxis. So apparently this is a strategy to reduce chances of acquiring HIV infection in persons at risk. And with this, what they do is that patient who's at risk or at high risk would actually be taking antiretroviral medications on a daily basis. And, you know, in conjunction also with them, I guess, not getting involved in risky behaviors. Apparently this is very beneficial. And then they give you like a whole bunch of, like a cocktail of different types of medications to basically prevent you from getting the virus. So this is similar to like when you work in a hospital and then maybe you got stuck by a needle. You have a window where you can get the post-exposure prophylaxis, where they'll give you medications. So they'll test you, they'll give you the medications, and you have to come back. So maybe it's at 3 months, and you come back at 3 months, and then you come back again at 6 months, so that they're testing you to see whether or not you were infected. All right. So, like I said, do not make any assumptions about who may be at risk. So you need to be having candid conversations with pretty much everyone who's showing up. Ask at-risk patients if they've received any blood transfusion or clotting factors before 1985. So before 1985, because this is when we weren't doing routine screenings, right? Talking about sharing drug equipment, talking about their sexual experiences, you know, having had any sexually transmitted infections. So really, really candid conversations. So the nurse can't be shy. If you're shy, the patient's going to be shy, right? So you cannot be shy. So just a very thorough assessment needs to be done. So the care, once again, aimed at adherence to drug regimens, adapting a healthy lifestyle, protecting others from HIV, making sure that the patient still has beneficial relationships with their significant others or their family members, you know, it's no longer a death sentence, right? Exploring spiritual issues and basically teaching the patient how to cope with the disease and its treatment. Okay, once again, prevention and health promotion. This is where the nurses really come into play. Main takeaway, once again, HIV infection is preventable. Prevention is critical. Encourage early detection and early intervention. Avoiding or modifying risky behaviors, right? Providing culturally sensitive, language appropriate, and age specific teaching and behavior change counseling. Being very comfortable talking about these sensitive topics. All right, so the best prevention is abstinence, but obviously not everybody's going to be doing that. So just making sure that they're using barriers such as condoms, and educating and counseling about pre-exposure prophylaxis as necessary. And then if they're doing risky behaviors like drug usage, you know, teaching about do not use drugs, do not sharing equipment, not having sexual intercourse under the influence, and then referring the patients for help that may have substance abuse issues. So with the women, preventing HIV in women is a goal. Then family planning, and then appropriately medicating HIV-infected pregnant women so you can decrease the risk that their child will be born with the virus. At work, so we have particular measures put in place, so needleless systems. If you are exposed, making sure that you are reporting that right away. And there's always a post-exposure prophylaxis that follows with combination ART therapy right afterwards. So I'm interested to find out from you guys if you know what that post-exposure prophylaxis looks like. So Lewis didn't really get into it that much, but that's something I would like to talk about. All right, so just remind me. So testing is the only sure method of determining HIV infection. So CDC recommends universal voluntary testing as part of routine medical care. Lots of people, 14%, living with HIV, not even aware that they're infected. All right, so the other stuff we worry about is the reaction to the positive HIV test, right? So yeah, though it's now considered like a chronic illness, it's still shocking to find out that you're HIV positive, right? So the usual types of feelings are going to show up. So panic, anxiety, fear, guilt, depression, denial, anger, and hopelessness, because people know that there is no cure, right? Yeah, you can live with it, but there's no cure, and there are implications. Maybe you're young when you get it. Maybe you're 18. Your life is just starting, right? You want to have kids, So it's just thinking about just how all of that will play out. Maybe you come from a very religious background, and now you're HIV positive. What does that mean in your family, in your culture, right? A lot of stigma, all those different types of things. And maybe you may be ostracized still in some cultures. So really just factoring all of those different types of reactions that the patient may have. So treatment is key. So ART therapy can slow HIV progression. It is complex, it has side effects, it doesn't work for everyone, and it is expensive. So you want to start ART therapy as quickly as possible. The patient will determine how well this is going to work. The compliance is going to determine how well the medications are going to work, right? Higher the compliance, the higher the chance is that, the patient has a higher chance of actually getting a decreased viral load in their body, right? Sure, maybe viral loads will be different across patients and maybe different immune systems, right? That's always a factor, but it's better to at least try taking the medications and seeing whether or not it's working for the patient, right? All right. So adherence. All right, so delaying the disease progression, so promoting a healthy immune system. So, there are other alternative therapies that will say that they've cured people with HIV, or, that they've cleansed their bodies, they've done cleanses, they've done, alkaline types of diets. So there are those claims being made, right? So anyway, you want to promote a healthy immune system. If the patient is open to other types of alternative therapies, you can't stop them from doing that. For sure, we want to eliminate anything that we know is problematic, right? So things like alcohol, tobacco, drug usage, all those types of things. Making sure that patients are up to date with vaccinations, rest, exercising, all those types of things. We want to make sure that we are providing it for our patient. So when a patient has the acute exacerbations and they have the infections, some of the things that they worry about is the fact that they know that there's no cure. This is a lifelong thing. It can cause physical disability. It can impair social, emotional, economic, and spiritual well-being. And, ultimately it does lead to death, right? Especially if the patient is not compliant with the treatment plan. So just making sure that, we're addressing all of this in some way. So also dealing with the negative social beliefs and attitudes surrounding HIV, stigma is still a thing. All right, so just assessing how this is affecting your particular patient. Some of the disease and drug side effects, so things like anxiety, fear, depression, from the medications and from the disease itself, you're getting weird things like diarrhea, peripheral neuropathy, pain, nausea, vomiting, and fatigue, right? So a lot of things you have to contend with. And then, because the patient has the infection and they've been on medications for a long time, they end up getting some metabolic disorders, right? So now they're getting other weird things that can happen. So the situation just gets exacerbated. So they have HIV, AIDS, getting treatment, weird things that happen in their body, and now they're getting all of these other weird things. Okay, and that's what your lipodystrophy looks like. All right, and then the end of life care here. So focus on nursing interventions once again for the patients that, unfortunately are not going to make it. And yeah, so giving emotional and spiritual acceptance, still keeping them comfortable. Some patients may end up in hospice. So just making sure that they're getting the treatment that they need. So the answer to my initial question, I was asking you guys at the beginning, which group of people is seeing an increased rise in infections? It's actually the older population. So, older people are in nursing homes, they're old. Some of them maybe are thinking they're dying, or maybe they just don't know, that they can get HIV, but there's a lot of sex happening in nursing homes. So the number of older adults with HIV disease is increasing. So a lot of that, potentially is lack of education. And I just don't know, what the other reasons might be, but you guys, we can talk about it. So people 60 and older are increasingly being infected. So this is definitely a big problem. So let's talk about why we think this is going on. And that's it.